Today's episode is brought to you by Microsoft Dragon Copilot, your AI assistant for clinical workflow, which helps to ease administrative burdens. Oh, I hate those. Lots of burdens. Lots of burdens. Automatically document care, streamline workflows, and promote a more focused clinician-patient experience. I know you'd love that.
Yes, I do.
Learn about how Dragon Copilot can transform the way you work. Visit aka.ms/knock-knock-high. Again, that's aka.ms/knock-knock-high.
Hey, Will.
Hey, what's up?
I've been thinking, the U.S. healthcare system, it needs some improvement.
Yeah, there's room for improvement.
Sure. It's a confusing, scary place for everybody involved.
Absolutely.
Physicians, families, patients, everybody.
Everybody. And I've experienced it from both sides, right? I'm a physician. I've also been a patient. So I wanted to use my platform to give people practical education, really the only way that I know how, by making jokes. So Dr. Glockenflecken's really fun and super uplifting guide to American healthcare is out, and it's a free resource that includes all my videos from the 30 Days of Healthcare series, alongside deeper explanations, also reliable facts, emphasis on reliable.
Yes.
All right. Figures, numbers, insights into how each of us can fight for a more humane, better healthcare system. Also, it has jokes.
Did you mention the jokes?
I did. Jokes. Okay. Yes, definitely jokes.
Well, this guide is great for anyone looking to learn more about U.S. healthcare, but especially if you are experiencing it from the clinician side for the first time.
That's right.
Really hope you'll check it out.
Get the free guide sent straight to your inbox by signing up for our mailing list, glockenflecken.com/healthcare. Enjoy. Hi. Hello, everybody. Welcome to Knock Knock Eye with me, your host, Dr. Glockenflecken, your one-stop shop for all things eyeballs. Welcome, friends. I hope you're having a wonderful day. I am having a great day. Had a wonderful day in the operating room, even though our computer system went down. There's nothing, talking about I swear the pit needs to do an episode where all that crazy stuff happens during the shift, but also the computer system's down. Just take it up to like 11. Just crank it up, crank up the stress, as if that show is not stressful enough as it is. The most recent episode of this podcast, of the Knock Knock Eye episodes, came out on YouTube, and it's by far the most popular episode so far, based on number of you who saw it on our YouTube channel at Glockenfleckens. And I think it's because everyone is talking about the pit, and that was a part of what that episode was about. I gave a review of a scene in the pit that involved eye trauma. And so go and check it out if you want. But I love the comments, so I'm going to address some of those comments, talk a little bit more about the pit here in a little bit. But first, I wanted to, usually at the start of these Knock Knock Eye, for those of you who are new, because I feel like I might have some new people, because a lot of your people are starting to find the podcast a little bit, which is awesome. I love it. Here at the start, I try to do some kind of a current events type thing, like in healthcare, and I try to make it at least somewhat healthcare related. Well, this time, a couple days ago, there was a video that came out. Apparently there's this, I think it's a web series. I'm not sure exactly what it is, but it's called Surrounded, where they have an expert sitting in the middle in this room, in this big room. They're sitting at a desk in the middle. There's like a timer. There's people are holding flags. I'm not totally sure how it works, but the whole idea is that there's people that surround the person in the middle in this big room. And these people take turns like racing to the center to debate this expert in something. So the only ones I've seen before, I saw clips of it. It was like Ben Shapiro, like the Republican guy. So I don't know. They must have, maybe they have like, all kinds of different special or professions of people doing things, but it's got to be some kind of hot button topic, right? Because it's a debate show. Well, the most recent episode they put out featured Dr. Mike. and he was talking about he was debating anti-vaxxers. So I'm going to talk a little bit about my thoughts of this episode, but I really, really encourage you. It's a long video on YouTube. You can find it on YouTube. It's over an hour, but it's I think it's interesting. It's fascinating just to see the interactions. So as far as Dr. Mike goes, I'm a fan. I'm a fan of Dr. Mike. You know, when he first got started, you know, he was like the when he first kind of blew up on social media, he was like the sexiest doctor guy, right? He was on the Today Show and all this stuff. But if you've paid attention to his platform and with his podcast, the Checkup, I think is what it's called. He has really interesting conversations, and he's really using his platform well in talking about vaccines in particular. And I applaud him greatly for even taking on this project, because man, the amount of vitriol and anger and misinformation and politicizing around the idea of vaccines that didn't exist 30, 40 years ago, back when like polio, people were getting, it was long, further back than that with polio, but you know, before Andrew Wakefield and all the, you know, vaccines cause autism stuff, you know, I wasn't around back then, but I can't imagine there was this much anger and dissent and just vitriol around this topic of vaccines. You know, you see the classic photos of kids with smallpox pre and post vaccine. It's just remarkable what vaccines can do. And then it goes on and on with polio and HPV and measles, mumps, rubella. You know, so anyway. But the point is, I'm not trying to like open up the whole vaccine thing, but I'm so impressed by Dr. Mike. Here's what I'm impressed by: just the fact that he did this, because I mean, I don't know if I could do it. Just it's daunting to think about like putting yourself in that position, and he did it gracefully. He dealt with that with professionalism. He stayed level-headed. He didn't get angry. He didn't raise his voice. He showed all of these people compassion. And I, like most of us in healthcare, proponents of vaccines, I don't think a lot of us would have been able to stay as calm as he was throughout that time. And I was able to connect with him about that. And he said that the taping was over 3 hours, like constant, like it was so much longer than the video shows. So there was a lot that was edited out. But so that is some perseverance of being able to do that for that long. And a lot of the interactions were, at least what we saw in the published post, was you know, there's a lot of anecdotal things, you know, people talking about you know, they knew somebody that, you know, the kid got vaccinated and then they started having seizures, or all these other issues. A lot of kind of coincidental type things. And I got so tired of hearing all of that, because that was a very common refrain. And that speaks to just people not really understanding like what evidence means, what evidence-based practice means. We have a lot of evidence that vaccines work. And so there's a knowledge gap there that was readily apparent pretty much immediately, you know, as soon as they started the back and forth debating. And he tried his best. He really did on trying to explain the difference, you know, between a coincident, two things that happened relatively close to one another versus like causality. It's like, you know, when I had a cardiac arrest back in May of 2020, and the night before the cardiac arrest, I had lasagna. Was it the lasagna that caused my cardiac arrest? Do I think that other people should not be eating lasagna because it might cause a cardiac arrest? It's like that line of thinking. Like, that's an extreme example, but I mean, this is all kind of extreme. But it's that way of thinking that a lot of people were bringing to this debate. And then at one point, there was even a person that was Dr. Mike asked, which is a great question. He's like, "Is there anything I can tell you, I can say, that would make you question or change your mind?" And the person was like, "No, nothing you will say." At that point, debate's done. Like, if I was in that situation, and I'm glad I wasn't, because I would not come off looking as good. I would have I was like, okay, see ya, and get up and walk away. I mean, at that point, like, what are we doing? What are we doing? And do I think that this was a useful way to like try to change minds? Probably not. I don't think that's a great format. I think it's sensationalized. Mike didn't have any control over the final edit of it, right? So they could have edited it to take out some of his answers or include other things that other people were saying. And clearly it was heavily edited. Did it change minds? Maybe, but, and I posted about this on social media. I said, I really am impressed by him because I think he represented the medical field well. People have so much distrust of physicians, and right now especially, like, I feel like it's being stoked, this like anger toward physicians. And he had to present himself professionally in that situation. He couldn't get angry at these people. It felt like a physician-patient relationship, and you can't get angry in those situations. And so I'm glad he was the one that did that. And I think he did a very admirable job. And so how do we reach people on vaccines? I mean, I don't think it's going to be stuff like this. I think it's going to be like real, honest, like personal interactions, in the exam rooms, in your, at family get-togethers with friends over drinks. That's where it's not going to happen on social media. I really don't think it's going to happen on social media. And so I heard some comments from people that were like, well, is it even worth it? Like, are we just platforming these inappropriate not inappropriate, but this misinformation, these arguments that don't have any bearing, that don't have any weight, that are not accurate? Are we just platforming misinformation? And is that just making it worse? And I pushed back on that, because all of these anti-vaccine arguments, they're out there. They're prevalent. They're everywhere. Every social media platform, everybody starts talking about vaccines. Maybe even in the comment section on this video when it gets published, people are going to spout those same arguments. And in the face of medical literature, of the evidence that we have that vaccines work. And so somebody has to be out there refuting this stuff. People get their information on social media now. We can't just have the wrong information not be challenged. And so I totally understand the criticism, like, he shouldn't have done it because it just platforms these people. I get that. I just don't agree with it, because somebody's got to do it. Like, we got to combat it. Otherwise, it's just going to run rampant and people are going to believe this stuff. It's going to reach parents of babies, of young kids, and they're not going to get their influenza or their Haemophilus vaccine, their Tdap, their whatever it is, MMR, and public health is going to suffer for it. And so we got to be on social media, and that's when I talk about social media, usually it's in the context of more health policy and health insurance companies, all the things I talk about a lot on social. I also make this point. I'm like, for the same reasons, like we got to have somebody out there. I encourage physicians, public health professionals, people who know a thing or two about medicine to have a social media presence, talk about the things that you know a lot about, bring accurate information to it, present it in a compelling, engaging manner, tell your stories, include the evidence. All that stuff can reach people. I don't know, but I think it's important, but and then it actually sounds like I'm going against what I just previously said, how, I don't think social media can actually change people's mind on vaccines. Maybe that's true. I think it's harder to do it on social media, but I don't want to live in the world where it's just one argument against vaccines that so many people see. We got to have other people presenting a different point of view. So thanks to Dr. Mike. I honestly really appreciate that he did that. And also, here's the other thing. He agreed to that knowing he was going to get a tremendous amount of hate, an unbelievable amount, like more than any of us have ever experienced on social media. The guy's got 15 million subscribers on YouTube. Like, Dr. Mike is the biggest physician in the world in terms of popularity, in terms of the number of people in this world who know who Dr. Mike is. Like, there's not a doctor that people know more than him. And so to put his name out there and knowing he's going to get lots of criticism, lots of hate on social media that might even potentially like get into his like real life too. Like, that's kind of scary to think about, but he did it anyway because he knows how important this message is. And so we should all level-headed people with a fully developed frontal lobe, like we all need to be, we all need to recognize what he's done and keep it going, right? I could do a better job of talking about stuff like this. And so, thanks for setting the example there, Mike. All right, let's take a break. Hey, Kristen.
Yeah.
I've been, grossing you out about these Demodex mites, although I'm not sure why. They look like adorable.
Well, these are cute, but it's the real ones that kind of freak me out a little bit.
Yeah, but I have some new facts to share with you about
great.
Demodex.
All right.
These mites have likely lived with us for millions of years.
Oh.
Yeah. Does that make you feel better?
No.
Like they're passed down through close contact, especially between mothers and babies.
Oh, wow. Such a special gift for our daughters.
They're born, they live, they crawl around, and then they die on your eyelids and in your lash follicles. Their entire life cycle lasts about 2 to 3 weeks, all spent on your eyelids.
Well, thank you for
This isn't helping, is it?
No. How do I get rid of them?
Well, it's fun to gross you out, but we do have all of these. It's really common, but there is a prescription eye drop to help with these now.
Okay.
That probably excites you.
That makes me feel better.
Any way to get rid of them, right?
That's right.
All right.
Sign me up.
Visit Mites Love Lids to learn more about Demodex blepharitis, which is the disease that these little guys cause.
Sure.
Again, that's MITES Love Lids, LOVELIDS.com to learn more about Demodex and Demodex blepharitis and how you can get rid of it. Okay, so we are back, and I'm going to go through a couple of comments on the latest YouTube video of this podcast. The title of the episode was "The Pit. Is this the most realistic medical show ever?" Which was I don't come up with these titles. I have a production team. My producers help post all these things and come up with some of the copy editing. They did a great job here, and because it is the most popular video, and I think it's just the algorithm is latched on to The Pit. Everybody's talking about The Pit. Great show. I have not caught up on all the episodes, but man, it is a gritty, like a white knuckle thrill ride. That's what people describe it as, I think. And so I'm going to read a couple of comments because I talked about it the last episode or a couple weeks ago. So at Kim Adla said, I totally get that the pit may seem scary or may feel like it's too unflattering for the ER or too stressful or real. And the reason she said that is because in that episode, I talked about some of the things that I had not really seen a whole lot of it at that point. And I saw some people on social media, obviously a lot of people praising it, but some people being like, it's like, it's so real that it might actually like turn people off of emergency medicine because it's like too scary. She goes on to say, watching that show felt like getting punched in the face repeatedly with how intense it is all the time. But with that said, as someone who was hoping to go to med school but was dreading emergency medicine and surgery rotations, the pit actually helped me feel better about it. So I love this comment because I think there's a lot of truth to this. I didn't think about it from this perspective. Like the pit is so crazy in its depiction of an emergency department that if you can handle that, if you can watch that and think, oh yeah, like I see myself doing that. Well, there's no way your job as an emergency physician is going to be that insane in that much of a concentrated way. Yeah, you may deal with all of those situations at some point in your career, but I mean, it's concentrated, right? Like not that many disasters doesn't happen hour after hour after hour after hour for like 12 straight hours. Like, but they're not going to make a show where you're like waiting for lab results for 45 minutes. So if you can, I love that perspective though. If you can see this show and still think, yeah, I could do that, then maybe that actually empowers you to choose emergency medicine as a field. I love it. That's great. At A Screen 8, the biggest criticism I've seen from other ED docs across YouTube is not that each scene is wrong, but rather most of these things are super bad and you just wouldn't get all of these things in one shift. Yeah, exactly. People are going nuts over this show. That's great. I think this is the next big thing, right? I mean, and I think a big part of it, a lot of people praising Noah Wiley's performance. And I mean, he's got some experience, right? I encourage you guys to go look at when Noah Wiley was John Carter as a med student. It's great. And so you see the incredible difference. And so I can't wait to finish, to keep watching the show because it's wild. And seeing what I talked about was this eye. They had this retrobulbar hemorrhage. They had to do a lateral canthotomy, cantholysis. By the way, happy to consult for this. Makers of the show, writers of the show. If you need more eyeball stuff, if you need me to show you what exactly it's like when an emergency physician sits down at a slit lamp and tries to remember what all the knobs and buttons do, like that's me. I'm your guy. If you ever want to depict an ophthalmologist scared to death as he walks through the emergency department trying to figure out where his patient is, I'm your guy. I can show you exactly what that's like. All right. I'll be the actor in it. I'll coach whoever it is, whoever you want to put in that role. That's come talk to me. Okay. I'll do it for free. You don't even have to pay me. I'll give you whatever you need. Somebody said, oh, here we go. At BD Fortes, Noah Wiley's character is 100% based on your emergency doctor character. So I'm pretty sure they should have credited you. I disagree. I disagree because my character is based on emergency physicians. So it's all credit to the actual real emergency physicians because I made my character based on all of you guys. And so, but they really, man, the acting on that show, the acting on the pit, just phenomenal. Check it out. Thank you for all those comments. Okay, so I did have another comment that had some good eyeball related questions here. Let me make sure people talking about, I mentioned the portable slit lamp and like functioning slit lamps and how that's not always the case. Portable slit lamps are expensive. So in the scene of the pit that I talked about, they brought out a portable slit lamp. Those things cost about $5,000. It's very expensive. no emergency department is going to shell out that kind of money. Not whenever they could buy like 2 more ultrasound probes for that amount of money. No, there's no way. They're not going to designate some of those funds for eyeball stuff. You kidding me? A new eye chart? No. New Tonopen? Get out of here. Tonopen tips, what we call eyeball condoms. They look like condoms, little Tonopen tips. Where was I? I'm all of a sudden talking about condoms. Oh, somebody said they were upset that no pharmacists. They said pharmacists are never shown in these shows. They need to have a pharmacy centric show. I feel like you could do a pretty good comedy based on like pharmacy. I don't know what you'd call it. I gotta brainstorm some good names for a pharmacy TV show, pharmacy based comedy television show. That'd be a good one. Oh, here we go. At XW Bonehead said, I have so many questions for you. He said, why can we do crossed eyes, like look medially, cross your eyes toward the middle, but not go the other way, abduction at the same time? How come your eyes can go together, but they don't go? Well, there's a functional reason why you want your eyes to come together, why you have a neurologic pathway that allows for convergence of your eyes. So we're talking about a normal situation here where your eyes will converge. They'll both move medially. And that's because you want to have binocular vision on things that you're using with your hands. So you can have hand-eye coordination. So you don't miss things when you're trying to eat or something like that, or read something. And so we have this wonderful thing called binocular vision. We have 2 eyes for a reason. We want to use them together. And so, yeah, that's why we have this amazing ability to converge our eyes. Certain diseases will take that away from you, by the way, certainly strokes, but also like Parkinson's disease is a common one. But the question is, how come we don't diverge our eyes? Well, we do. We diverge them whenever we're converged, and then we want to put them back to normal. There's no reason why we would want to be able to diverge our eyes further, because that would take away our wonderful stereopsis, our wonderful binocular vision. We wouldn't have it anymore. We'd be chameleons. All right. I don't even begin to understand how their vision works. And so we don't need to be able to do that, but we do have pathways along our visual system that allows us to diverge our eyes. And there is a thing called divergence insufficiency. Patients with that have this inability to diverge the eyes, and so they're constantly converged. There's a divergence, and you can actually end up getting surgery for that to help put your eyes a little bit further apart. So they're not, if you're watching on YouTube, I'm like moving my hands in and out constantly with convergence, divergence. So some people have an inability to do the normal amount of divergence that our eyes have the ability to do. But that's a great question. Another question was, I love this one. It says, what's the deal with retinal scans as a form of identification? Does it really work? Will it still work if there are vascular changes, degeneration, or other retinal diseases? I'll be honest. This is something I never even thought about. So you see these sci-fi, spy movies, whatever, like they're trying to get into some vault or locked door, they get a retinal scan. What's that measuring? Well, we all have a unique retina appearance. So what it's measuring when you see a retinal scan is your unique vasculature, the pattern of your vessels in the back part of the eye. It's unique, just like your fingerprints. Right? Nobody's going to have the same pattern of vasculature. No one's eye is going to develop the same exact way. So it's going to be a unique architecture back there. But what happens if you have diabetic retinopathy? Or let's say you have a central retinal artery occlusion or a branch retinal artery occlusion where you have narrowing of those arteries. Or maybe you have retinitis pigmentosa, where you have significant arteriolar narrowing. Or maybe you have a branch retinal vein occlusion. Basically, just anything that could change the vasculature of the back part of the eye. Well, you'd have to reset your retinal scan, wouldn't you? I didn't think about that. Like, man, that would suck. Like all of a sudden over time, things change. You got bad diabetes. You get you all of a sudden you have blood sugars for a few days over over 600, and all of a sudden you have a blown vein or artery back there, and your retina scan doesn't work. You're locked out of your vault. End of the movie. Sad. That's no fun. So yeah, you'd have to get a new scan if your vasculature changes. I imagine they have to update those every so often. That's great. It said, and will it still work? Another part of this question. Will it still work if the eye is blinded by a kraken disguised as a kitten? As in the case of Nick Fury from Marvel. Obviously, you have to be able to see back into the retina for a retinal scan to work. Now, other types of scans, you can do an iris scan. We actually do that in ophthalmology. So we have certain lasers that will register the position of the eye. I'm thinking mostly in doing LASIK or PRK or laser refractive surgery. It registers your iris, the architecture of your iris, to determine how to orient the laser. So there's iris registration. And because everybody's iris is unique, just like everybody's retina is unique. So we do have that kind of technology that we use in ophthalmology a lot. But things can happen to your iris. You could have transillumination defects with pigment dispersion syndrome, where you have the lens behind the iris that chafes the back of your iris, that chafes off a lot of the pigment that leads to what we call TIDs, transillumination defects. You have light that can get through the iris. That can change the architecture of your iris. You can get smoothing of the iris. You can get certain diseases, Cogan-Reese. There's all kinds of stuff. So trauma as well. That can change the architecture of your iris or your retina. It's really bad trauma. That's no good. Those are great questions. And then I do have one eyeball topic that I'm going to get to. You know what? We'll take one more quick break. We'll come back with a real quick little eyeball topic. All right, before we get to my eyeball topic, which is floppy eyelids. I think I've maybe talked about this before, but it came up on call. I just got off a week of call, you guys. That's why if it sounds like I'm in a really good mood, it's because I'm no longer on call. And yes, it's private practice call, and this was I'm going to challenge the call gods right now. I can do that because I'm not on call for another 4 months. It was one of my easier call weeks. I got a total of 6 calls. 5 of them were just patient phone calls. What do I do with my drops? I didn't get my drops. I'm having flashes of light. And it was like a come in, see me in clinic in the morning kind of situation. 1 call from an emergency department that I don't take call for. Our practice doesn't. So it was a mistake. So a shout out to all the wonderful emergency physicians in the area, because I know there are a lot more eye patients that came in than you told me about. I appreciate you. You do a bang up job. Wonderful. Some of you actually know how to use a slit lamp, which is awesome. And the calls I did get, made sense, although there's only that one. Still, it clearly did a good job, even though I don't take call there. And so thank you. Thank you for making my life easier. I know that's the goal of your job, is to make me, the private practice ophthalmologist, have an easy life. But I took a call from a patient who ended up having some floppy eyelids. So I'm going to talk about that in a second. But first, I need some advice from you guys. So I'm always trying to come up with new content strategies, other things I can do, because one thing I think I'm pretty good at is taking a relatively complex topic and somehow making it funny. I do this with the healthcare stuff. I've been doing it with the New England Journal of Medicine videos. Some of these cardiology trials where you're talking about catheter ablation versus antiarrhythmic therapy for ventricular tachycardia, that is not a funny thing. So my job is to try to find some humor in it. And I've gotten a lot of practice doing that. So I thought, okay, what else can I do? I've been doing the trials. What about just general medical knowledge? What about medical knowledge that maybe it can be for med students and residents and stuff, but also just the general public? Well, the problem is I am an ophthalmologist, you guys. I could do those types of skits and make it about eyeball stuff, but I don't have a lot of expertise when it comes to like pneumonia or sleep apnea, which I'll talk about in a second, or myocardial infarction. Or even like basic physiology. I got to remind myself all of this stuff. So you know what I did? To this end, I bought the most recent edition of First Aid, USMLE Step 1, First Aid. Oh man, there are a lot of pages here. This is a 600 page book. It's going, including the index, it goes to 800 pages. Is this what's in med students' brains? Like, you guys know all of this stuff? How? That there's no way. There's a lot of words. It's I've never been more impressed with the next generation of physicians, because my book was not anywhere near this thick. So I immediately got discouraged in thinking, like, I don't know if I can do this. I was like, maybe I could just like keep making videos over time. I'll pick like some random topic like afterload, like cardiac, afterload, and just like explain it in a skit featuring like, I don't know, ortho and cardiology, or cardiology and nephrology, and they argue about something. I don't know. But then I saw how thick this book was. Like, that would take the rest of my career. I would need like some kind of grant so I can quit my job and just focus on this for the next 20 years. Anyway, I don't know. I'm still playing around with it. What do you think, though? I'd love to hear your thoughts. Like, is this something, would you like to see, like, just topics, random topics? Let's choose one, like some kind of, like bile duct stones. I don't know, just a random thing, and like have me educate you about it, about a disease or something in physiology or anatomical structure or something, and learn about it in skit format. Because the idea interests me, because I like to push myself a little bit. The New England Journal of Medicine things have been really fun, trying to make these really bland sounding trials into something fun and engaging. And so it's like, let's do it for some like general medical stuff. So anyway, I have all the information I could ever need in this book. I think I just need, maybe what I need is some topic, ideas from you guys. Like, what do you want to hear about in skit format? So please, like, help me out. Send me some ideas. Comment in the YouTube, comments here at Glaucomfleckens. All right, and finally, I promised you I'd give you some kind of eyeball thing, floppy eyelids. So I saw a patient on call with floppy eyelids, and floppy eyelids they lead to dry eye. This is the biggest thing. So you have patients, they have like irritated, they have red eyes, they're waking up. This is a classic. Patients who wake up with really dry, sandy, like it feels like there's a rock in there. And then they can kind of get it better throughout the day, but then they wake up the next morning, same thing. One of the questions I always ask these types of patients, and these are all like kind of vague, non-specific symptoms, just irritated. Oh, my eyes sometimes they just feel heavy, a little bit of blurry vision, but generally their eyes, like the vision's okay. I always ask these patients, do you have sleep apnea? Specifically, do you use a CPAP or a BiPAP? This is because obstructive sleep apnea has a strong association with bilateral eyelid malposition known as floppy eyelid syndrome. So what this looks like on exam is I can take my finger on the outer part of their upper eyelid, and I just lift it up. And if that eyelid everts, if it turns inside out with just me trying to lift it up, if it turns out, your eyelid should not turn inside out if you just lift it with your finger. But if it does, you got floppy eyelid syndrome and you might have sleep apnea. So honestly, you can see that if you have that issue, like get us, and you don't know if you have sleep, you haven't been diagnosed with sleep apnea, I encourage you, go see your doctor, get a sleep study, especially if you snore. You might, I snore and I don't have sleep apnea. But I did get a sleep study because I had a cardiac arrest, and they're like grasping at straws, trying to come up with any possible reason why I might have had a cardiac arrest. But snoring is another thing that goes with obstructive sleep apnea. So anyway, this is, and then so people, I just put my eyelid. Very easy to diagnose this. You pull the eyelid up, it everts, floppy eyelids, and the reason this is worse in the morning when people wake up is because often whenever you're sleeping, well, first of all, if you're wearing a BiPAP or CPAP, the air, often you don't have a good seal, and that air can blow up into your eyes and cause worse. It's just air blowing. Imagine air blowing directly on your eyeball. Like, that's not good for dry eye. Also, people, if your eyelids are so malleable and floppy, then if you sleep the wrong way, if you're on your side, then you could actually sleep with your eyelids kind of pushed open and everted. And so you're just all night, you just got your eyes just open, exposed to air. You're going to wake up with severe dry eye. And so how do we treat this? Well, the most conservative thing to do for this problem is over-the-counter ointment. So just aggressive lubrication. We want to provide a barrier. Sometimes we have to give people what are called moisture goggles, basically like swim goggles almost, that you put a little ointment in the eye, you put a protective, comfortable pair of goggles on that keeps the air from causing dry eye and blowing directly onto the eye. Another thing, though, this can be managed surgically as well. So in ophthalmology, we have wonderful physicians that are known as oculoplastics specialists. And what they can do is a full thickness wedge resection. When you have floppy eyelids, you just have too much eyelid. You don't need all that eyelid. The tissue has been stretched out. It's redundant. You have redundant eyelid tissue. And so you can just take a wedge out of the eyelid and suture the ends together, shorten the eyelid basically. And that will prevent the eyelid from having enough tissue to be able to just spontaneously evert with just a little bit of pressure. Another thing you can do is sometimes you can do what's called a tarsorrhaphy. This is a terrifying sounding procedure where you suture the eyelids together. Now, it's not the entire eyelid. We have lateral tarsorrhaphies. We have medial tarsorrhaphies. We do have complete tarsorrhaphies where the whole eyelid is sutured shut. Maybe another episode I can talk about why we might want to do that. But in this situation for floppy eyelid syndrome, a tarsorrhaphy can just provide a little bit more protection to the surface of the eye. Because if let's say you just do like a lateral tarsorrhaphy of like a third of the eyelid opening. That's 1/3 more coverage that you can provide to the cornea. So you just close the outer part of the eyelid. You can still see. All right. You don't need the lateral part of the eyelids. They can be closed a little bit and you can still see. Do it to yourself. Close the lateral part of your eyelids. You can still see out of that eye. All right. So anyway, we'll do that for people to give them a little bit better coverage. That's typically when we do that, it can be a temporary thing, but often it becomes permanent. Because you can live a normal life. It might affect your peripheral vision just a little bit, but not enough that it prevents you from driving or doing daily tasks, unless you're like a fighter pilot or something. In which case, you're probably not doing that, because I doubt they let people with obstructive sleep apnea become a fighter pilot. I don't know. It's like, I feel like you have to be the picture perfect health, the perfect picture of health to be a fighter pilot. That's actually one of my go-to jokes for people. It's like when people are worried that something is going to prevent them from being able to live their life normally, I always tell them, well, if you have macular degeneration, like, you can't be a fighter pilot. And this is like a 75-year-old woman I'm talking to, right? And it always gets people to laugh a little bit. So it's a good one. Anyway, so that's just a little bit about floppy eyelids. So be aware of that. And this is something that not even, you can look at this as a primary care doc in the emergency department. You have someone with these types of symptoms that come in. I don't know why they're going to the emergency department, but that's fine. Anybody can do this. It's just eyelid, pull it up. If it inverts spontaneously with minimal lifting, they got floppy eyelids, especially if they got a history of CPAP use. So you can do that, and then you can talk about obstructive sleep apnea. You can refer the patient for a sleep study, all that stuff, and then obviously send them over to your neighborhood-friendly ophthalmologist. That's it. That's our episode for today. Thank you all for listening. I'm your host, Will Flannery, also known as Dr. Glaucomflecken. Thanks to our executive producers, Aaron Courtney, Rob Goldman, and Shanti Brick. Editor and engineers, Jason Pertizzi. Our music is by Omer Binsby. By the way, you guys like these episodes? Because I like making them. Like, can you give us like a nice, happy review on like wherever you get your podcast, Apple, Spotify, Google, wherever, I don't know, and like tell people about it. It's just, it's fun. I like giving knowledge to people. I like talking about these things. And so tell people if they want to learn about eyeballs, come on, check out Dr. Glaucomflecken's thing. All right. Thank you all for listening. Knock Knock Hi is a human content production. I will see you next week.
Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.